occlusion is previously defined as the act of closure or being closed. It is also defined as a static morphological tooth-contact relationship in function or parafunction. However, the term occlusion refers not only to contact at an occlusal interface but also to all those factors concerned with the development and stability of the masticatory system. Occlusion is more than a static relationship, but there is also a functional component that must be considered. Several researchers have tried to define an ideal occlusion, and one of them is Edward Angle, the father of modern orthodontics. Ideal occlusion is now defined as the harmonious static and dynamic relationship of the teeth and the jaws. So now it also includes the jaws in a dynamic relationship. Dr. Edward Angler first defined three classes of jaw relationships in 1887. Class 1 being considered as the ideal occlusion. Ideal class 1 occlusion is also referred to as a normal occlusion or neutral occlusion. We have a class 1 molar relationship and a class 1 canine relationship. This is a class 1 molar relationship wherein the mesiobuccal cusp tip of the maxillary first molar coincide with the mesiobuccal groove of the mandibular first molar. In a class 1 canine relationship, the cusp tip of the maxillary canine coincides with the facial embouchure between the mandibular canine and the first premolar. The facial profile of a person with class 1 occlusion tends to form a rather straight line from the top half of the face to the anterior border of the mandible. This facial profile is called orthognatic. These are the other characteristics of an ideal class 1 occlusion. There is a normal overjet or horizontal overlap wherein the maxillary anteriors are found anterior or more wherein the maxillary anteriors are found ahead of the mandibular anteriors. In an ideal class 1 occlusion, there is also a normal vertical overlap or overbite, such as in this picture. Okay? In a normal overbite, the incisal edge of the maxillary anteriors covers or hides the 1 to 2 millimeter of the incisal edges of the mandibular anterior teeth. This is a case of a patient with a lip bite. You can see here that the maxillary centrals covers the entire mandibular centrals. In an ideal class 1 occlusion, the buccal cusps and the buccal surfaces of the maxillary posteriors are buccal to those in the mandibular arch, whereas the lingual cusps and the lingual surfaces of the mandibular posteriors are found lingual to those in the maxillary arch. A cusp-fossa relationship is also present in an ideal class 1 occlusion. A cusp-fossa relationship refers to the position of the lingual cusps of the maxillary posteriors resting in the occlusal fossa of the mandibular teeth, and the buccal cusps of the mandibular posteriors resting in the occlusal fossa of the maxillary teeth. The cusps that rest in the occlusal fossa of the opposing tooth are called the functioning cusps. So for the maxillary posteriors, the functioning cusps are the lingual cusps, while for the mandibular, the functioning cusps are the buccal cusps. Those cusps that do not occlude on the central fossa of the opposing tooth are called the supporting cusps, rather. Ideal class 1 occlusion also shows perfect interdigitation of all of the upper and the lower teeth. The long axis midline of each maxillary tooth is positioned slightly distal to that of the corresponding mandibular tooth. Okay. This is a class 1 canine relationship wherein the cusp tip of the maxillary canine coincides with the embouchure between the mandibular canine and the mandibular first premolar. If there is any deviation from the ideal occlusion, it is technically referred to as malocclusion. So these are a few of the terms defining poor alignment of teeth within the arch. Labioversion or buccoversion is when the tooth is out of alignment and is positioned labial or buccal compared to the ideal arch form. Lingoversion is when the tooth is positioned lingual to the ideal arch form. Torsiversion is when the tooth is twisted or rotated around its tooth axis. Supraerupted or extruded teeth are long relative to the rest of the occlusal surfaces. Infraoccluded or infraverted teeth are abnormally short relative to the rest of the occlusal plane. So in this clinical picture, the mandibular left central is labioverted, while the maxillary right central is lingoverted. In this picture, the maxillary right central is rotated or torsiverted. Okay. The maxillary third molar is supraerupted. These are the terms related to tooth-to-tooth malocclusion. So when the buccal cusps of the maxillary posterior lines up directly over the mandibular buccal cusps, or when the maxillary incisal edges line up touching the mandibular incisal edges without vertical overlap, that is referred to as an end-to-end occlusion. Posterior crossbite or reverse articulation is when the mandibular posteriors are positioned too far buccally, or both cusps of the mandibular teeth are positioned lingual to the maxillary teeth. Anterior crossbite is when the mandibular anterior teeth are facial or is ahead to the maxillary anteriors. Anterior open bite is when there is a space between opposing incisal edges when the posteriors occlude. So in this clinical picture again, you can see here that the posterior teeth is in a reverse articulation. So this is a posterior crossbite. Okay. Here is an end-to-end occlusion, even here. We have two types of posterior crossbite. One is when the maxillary molars are too buccal or the mandibular molars are too lingual. The other one is when the mandibular molars are too buccal or the maxillary molars are too lingual. Okay. This is anterior crossbite. So the mandibular anterior teeth is ahead of the maxillary anterior teeth. So just like here. So here we have a negative overjet. Yeah. This is a clinical picture or a picture of a diagnostic cast showing an anterior open bite. See here that the posterior teeth are properly occluded, or there is tooth-to-tooth contact here, but there is a space here in the anterior area. Premature contacts refer to poorly aligned teeth that occlude before other teeth in the mouth. The premature contacts could also be called deflective occlusal contacts if upon closing in a posterior position, the teeth do not close directly into best or tightest fit but instead hit the prematurity first, deflecting the mandible before it can reach maximum intercuspation. Class 2 malocclusion is also referred to as distal occlusion, okay? Because the mandibular teeth is in a distal or posterior relationship with their normal maxillary opponents, just like here in the picture. The mesiobuccal groove of the mandibular first molar is distal or posterior to the mesiobuccal cusp of the maxillary first molar by a distance at least the width of a premolar. Class 2 malocclusion is a result of a small mandible, a large maxilla, or a combination of both. The facial profile of a patient with class 2 malocclusion is retrognatic, such that the person has a receded chin, resulting in a profile that is convex. Class 2 malocclusion has two subdivisions. So we have Class 2 Division 1, wherein the maxillary and mandibular incisors both flare labially. In a Class 2 Division 2, the maxillary central incisors are retruded with severe lingual inclination, while the maxillary lateral incisors are labially inclined. People with Class 2 Division 1 relationship often exhibit unique oral traits including a severe horizontal overjet, just like here, and supereruption of the mandibular incisors. So this mandibular incisor may supererupt because the lingual surface of the maxillary incisors was not able to prevent this from supererupting. People with Class 2 Division 2 malocclusion are likely to have other unique morphology including very little horizontal overjet but severe overbite. Okay, so you see here that there may be a severe overbite or a deep bite. Class 3 malocclusion is referred to as mesoocclusion because here the mandibular arch is anterior or more mesial to the maxillary arch. The mesiobuccal groove of the mandibular first molar is mesial or anterior to the mesiobuccal cusp of the maxillary first molar by at least the width of a premolar. This is a result of a large mandible or a mandible larger than the maxilla. Facial profile of patient with class 3 malocclusion is prognatic. They have a very prominent chin. That's why their facial profile is concave. Expect that these patients exhibit anterior crossbite. There are also terms that describe the primary molar relationship. So first is the flush terminal plane, wherein the distal surfaces of the maxillary E is ahead to that of the mandibular E. Let me correct myself. A flush terminal plane is when the distal surfaces of the maxillary and the mandibular E or the primary second molar coincide in a line. Distal step is when the distal surface of maxillary E is ahead to that of the mandibular E. Mesial step is when the distal surface of maxillary E is behind, posterior, or distal to that of the mandibular E. This is a distal step. This is a mesial step. This is a flush terminal relationship. These three primary molar relationships dictate the future molar relationship of the permanent teeth. There, there are several factors that contribute to that development, including the forward growth of the mandible, because at this point, the jaw of the patient is not yet fully developed. The shifting of the teeth also contributes to the development. With minimal growth differential, the distal step could develop in a class 2 malocclusion, and the flush terminal plane can develop into an end-to-end relationship, the mesial step into a class 1 occlusion. Together with the shift of the teeth, indicated by the broken arrows, distal step could become an end-to-end relationship, flush terminal plane can become a class 1 relationship, and the mesial step can become a class 3 relationship. With the forward growth of the mandible alone, can cause these molar relationships to develop into the molar relationships previously mentioned. Keep in mind that the goal is to have a class 1 normal occlusion. These are the following terms that describe the jaw relationships between the mandible and the maxilla. Protrusive movement and lateral translation are called eccentric jaw relationships. When we say eccentric, these are the movements of the mandible that are deviations from the centric relation position. First is the maximum intercuspal position. So it is also referred to as the centric occlusion. Okay? This is a tooth-to-tooth relationship and independent on jaw muscles or joint anatomy. So it is a purely tooth-determined position. Centric occlusion is the tightest or best fit when both maxillary and mandibular posterior teeth occludes. Okay, so this is maximum intercuspation. So you see that the maxillary teeth and the mandibular teeth occludes in a cusp-fossa relationship. Centric jaw relation or centric relation, on the other hand, is a jaw-to-jaw relation. It is not affected by the presence or the absence of teeth, and it does not change due to malocclusion. Centric jaw relation or CJR is reproducible and repeatable because it is the relationship of the jaw that people return to each time they chew and swallow. So in a centric jaw relation, there is no contact of the teeth, and the condyles are in the uppermost position in the glenoid fossa. Okay? The centric jaw relation includes the range of positions of the mandible during rotational movements without translation and without the teeth touching. These are the other definitions of the CJR. So this is the most protruded physiologic relation of the mandible to the maxilla, to and from which the individual can make lateral movements. This is also the most posterior relation of the mandible to the maxilla at the established vertical dimension. So what is vertical dimension? Vertical dimension of rest position is also referred to as the physiologic rest position. In this is the position of the mandible in which all the supporting muscles are in resting posture. The person's head is upright. The muscles of mandibular movements are in equilibrium, and the condyles are in an unrestrained position. Okay? So vertical dimension is the distance between a selected point on the mandible and a selected point in the maxilla. So we have two types of vertical dimension. The vertical dimension at rest, or VDR, and the vertical dimension in occlusion, or VDO. Okay? The vertical dimension produced when the teeth are in maximum intercuspation, that is the vertical dimension of occlusion. Okay? When the vertical dimension measured in physiologic rest position is referred to as the vertical dimension of rest position. VDR is always greater than VDO. When the patient is in physiologic rest position, there is a space between the occlusal surfaces of the maxillary and the mandibular teeth. That space is called the interocclusal rest space or freeway space, which is about 2 to 4 millimeters. Next is the protrusive jaw relation. So when the mandible moves anteriorly, the condyles and the discs move forward together. Again, the movement of the condyle and the disc is guided by the sloping morphology of the articular eminence. As protrusion occurs, the movement of the mandible is also influenced by the amount of overlap of the anterior teeth. Given a patient with normal overbite and overjet, when the mandible moves anteriorly, the incisal edges of the mandibular anteriors glide against the lingual surface of the maxillary anteriors, thereby also guiding the mandible downward. Okay? This is known as the incisal guidance. Incisal guidance is a type of anterior guidance or anterior protected articulation. It is called anterior protected articulation because when the anterior teeth articulates during protrusion, it causes disocclusion of the posterior teeth, thereby protecting it from harmful occlusal forces. Opposite to protrusive jaw relation is the retrusion of the mandible, wherein the mandible moves posteriorly until it reaches maximum intercuspal position. Okay. This is the Posselt's envelope of motion. Okay? It shows the movements of the condyle here in relation to the movements of the mandible. Okay? The Posselt's envelope of motion is the schematic representation of mandibular movements in sagittal plane. So it shows the different basic positions of the mandible. So CO is the centric occlusion. CR is the centric relation. Okay. R is the rest position. So you can see here that the CO or centric occlusion is different from the rest position. This space here is the freeway space. E refers to the maximum opening, F maximum protrusion. Okay? When the mandible moves from CR to B or halfway of the maximum opening of the mandible, there is only hinge movement or rotational movement in the condyle. Okay? But when from the centric relation, the mandible moves to maximum opening, so there is already downward and forward movement of the mandible. So Posselt's envelope of motion also refers to the limit of the movement of the mandible, the functional limit of the movements of the mandible. During these movements, this is how the condyle and the mandible moves. During lateral translation, only one condyle moves downward and forward. This is in comparison to the protrusion. When during protrusive jaw movement, the both condyles, both right and left condyles, move downward and forward together. Again, in lateral mandibular relation, that is not the case. Only one condyle moves forward, downward, and medially, while the other condyle rotates on an axis. So during lateral translation, we have a working side and a non-working or balancing side. Working side is the side toward which the mandible moves during lateral excursion, and it is termed working side because it is where the chewing occurs. The condyle on the working side is the one with the hinge movement only. Okay. Non-working side or balancing side is the opposite side. The condyle on this side is the one with translational movement. This is Bennett movement, so it shows the movement of the mandible during protrusion and lateral translation. Okay. So during protrusion, the condyle moves, both condyles moves downward and forward. Okay, here, this one, this one. During lateral translation, only one condyle moves downward, forward, and medially. The other condyle rotates on an axis. Okay, so in this schematic diagram, the mandible moves towards the right side. So this is the right side, this is the left side. So again, the mandible moves towards the right side. Okay? When the mandible moves towards the right side, this is referred to as the working side because the chewing occurs here. This is now the non-working or the balancing side. However, in the temporomandibular joint, we have an opposite relationship or a reverse relationship. In the working side, the condyle only rotates on its axis. So this is only the movement of the condyle in the working side. Your condyle now is the balancing condyle. So again, on the working side, we only have the balancing condyle, which rotates on its axis. On the non-working side, the condyle moves downward, forward, and medially. Okay. Downward, forward, and medial movement of the mandible is translational movement. Okay. This is now the working condyle. So on the non-working side or the balancing side, we have the working condyle. Okay. So we have three types in guidance of the occlusions. We have the canine protected articulation, the incisal guidance, which was previously described, and the group function or unilateral balance occlusion. The canine protected articulation is also a form of anterior guidance. Okay, so both canine protected and incisal guidance or anterior guidance of occlusion. Okay, so the difference of the canine protected articulation from the incisal guidance is only the canines contact during protrusive or lateral movements. Okay, in comparison with group function or unilateral balance occlusion, where multiple teeth on working side contact evenly as the jaws move toward that side. The canine protected articulation is desirable because it causes disocclusion of the posterior teeth during eccentric movements. During eccentric movements, there is the occlusal forces are not directed to the long axis of the tooth, okay, which is undesirable. Okay, so when the canine occludes in a canine protected articulation, the posterior teeth do not contact each other. Thereby, these teeth will be spared from the harmful occlusal forces. So these are the references. The occlusion described here is limited only. Okay? When we go to orthodontics, to your prosthodontics, occlusion will be described further.